You know, you probably have a morning routine that looks, I mean, at least somewhat similar to mine.
Oh, definitely.
Right. You stumble out of bed, you brush your teeth, flip on the bathroom light, and you just sort of glance in the mirror.
Yeah, just to check for the basics.
Exactly. Like making sure you don't have, I don't know, severe bedhead or some toothpaste lingering on your chin.
Right.
It's a completely functional moment. You gather a quick point of data about your physical state, and then, you just move on with your life.
Well, yeah, because it's a passive interaction for most people. I mean, you are simply acquiring the visual information required to confirm you're presentable.
Right, to society.
Exactly. The reflection is nothing more than a reflection. It really holds no emotional weight.
But imagine, just for a second, if that interaction wasn't passive.
Oh.
Right. Imagine if the mirror didn't show you a whole face, but instead functioned like a high-powered camera permanently stuck on a severe macro setting.
That sounds intense.
It is. It forcefully zooms in on one microscopic detail. Maybe it's a single pore on your cheek or a slight curve in your nose.
Right.
And it magnifies it until it eclipses literally everything else. And the most terrifying part isn't even just the visual distortion.
What is it then?
It's that looking at this distorted image triggers a profound, overwhelming, just physical sense of panic.
Which, I mean, fundamentally changes the entire experience of occupying your own body.
Exactly.
You're no longer doing a quick data check before work. You're confronting a daily visceral terror just by passing, a reflective surface.
So welcome to today's deep dive. We're exploring a really fascinating and honestly intensely misunderstood psychological condition.
Yes, we are.
And we're using our research stack for today, which includes some clinical insights from a document titled The Mirror of Obsession: Understanding Body Dysmorphic Disorder.
Such an important text.
It really is. And alongside that, we have some revealing operational data from a telehealth practice that's currently treating this condition, right on the front lines.
Which gives us some great real-world context.
For sure. So our mission today is to shatter common misconceptions about body image struggles, to truly grasp the intense reality of body dysmorphic disorder.
Which we'll just call BDD for
Right,
short.
exactly, BDD.
Yeah.
And we're going to explore exactly how the medical and therapeutic fields are actually addressing it today.
It's a critical conversation.
It really is. Okay, let's unpack this, because the very first thing we have to tackle is the core myth surrounding BDD.
The vanity myth.
Yes. The myth that this is simply, an extreme form of vanity. But the clinical definition tells a completely different story.
Great way it does.
Because BDD involves a severe preoccupation with perceived physical flaws that are either completely unobservable to everyone else or, incredibly slight.
And starting with that definition is crucial. I mean, to call this vanity is to completely misunderstand the architecture of the human brain.
Oh, absolutely.
Vanity implies an ego-driven, arrogant obsession with one's own attractiveness. But BDD is the absolute inverse of that.
It's the opposite.
Exactly. It's rooted in deep distress, shame, and functional impairment. And just to put the sheer scale of this into perspective, epidemiological data indicates this condition affects approximately 2.4% of U.S. adults.
2.4%.
Yeah.
I mean, when you actually pause and map that onto the population of the United States, that is a staggering number of people.
It's huge.
We are talking about millions of adults.
Yeah.
Like people you pass in the grocery store, people sitting in the cubicle next to you.
Just carrying this massive invisible burden every single day.
Yeah.
It's an enormous demographic for a condition that honestly remains so heavily stigmatized and hidden.
So hidden, yeah.
And to understand why it affects those millions of adults so severely, we really have to look under the hood at what is actually happening in the brain's perceptual centers.
Right, because this isn't just someone being overly critical.
No, not at all. The distress they feel is not a choice. It's a fundamental misfiring of the brain's visual processing and emotional regulation systems.
Let's get into the mechanics of that misfiring then, because the clinical notes list some very specific targets of this fixation.
They do.
People with BDD might obsess over their skin texture, their hair, the shape of their nose, weight distribution, body asymmetry.
Or honestly, anything.
Right. The documentation notes it could be virtually any feature. But I really want to understand the how here.
Yeah.
Like, how does a normal, rational person become completely paralyzed by something like skin texture.
Well, what's fascinating here is that the psychological distress is entirely real, even if the physical flaw is an illusion.
Okay, an illusion. How so?
Researchers have actually done brain imaging studies on patients with BDD, and they found that their brains process visual information completely differently.
Oh, wow.
Yeah, most of us use what's called global processing when we look at faces or bodies. We see the whole picture.
The forest, not the trees.
Exactly. But people with BDD tend to overutilize local processing.
Meaning what exactly?
Their brain literally bypasses the whole face and zeroes in on tiny, isolated details.
Wait, so they literally aren't seeing what we are seeing?
They really aren't.
It's almost like having a magnifying glass glued to your eye that just blurs out the rest of who you are. It's a hardware issue in how the visual data is being sorted.
Yes, that's a great way to put it. And it gets way more complicated when that skewed visual data is handed off to the amygdala.
Which is the brain's threat detection center, right?
Right. For someone with BDD, the brain registers that magnified detail, that pore, that slight asymmetry, as a massive glaring defect that the whole world is judging.
Oh, man.
And this triggers a legitimate biochemical fight-or-flight response. I mean, this is not vanity. It's profound psychological distress that shapes their entire reality.
I really want you, the listener, to pause and just imagine the sheer exhaustion of that.
It has to be exhausting.
Imagine your own brain treating your reflection as a mortal threat. Every single time you pass a store window, a rear-view mirror, or even like your phone screen when it goes dark.
Just relentless.
It's a relentless, exhausting cognitive load,
Yeah.
which naturally leads to the next phase, which is coping.
Right.
Because if you're in a constant state of distress, your brain demands that you do something to relieve the pressure.
Right.
Yeah.
Precisely. The distress absolutely demands a response. When the brain registers a threat, it basically compels the individual to neutralize that threat.
Which creates a loop.
Yeah, this creates the debilitating behavioral loop of BDD. The person desperately tries to find a way to verify the flaw, fix it, or hide it.
And the rituals described in our notes are staggering.
Really intense.
We are talking about people spending literal hours every single day examining the perceived flaw. Constant mirror checking.
Excessive grooming, too, to try and camouflage it.
Yes, and seeking constant reassurance from friends or family, always asking, does this look bad? Can you see this?
Which never really helps.
No. And then engaging in this endless, exhausting cycle of comparing their own appearance to every single person they pass on the street.
And we have to recognize that these behaviors aren't just physical actions either.
What do you mean?
Well, the clinical data notes that these morph into mental acts as well.
Mental acts.
Yeah, so even if they are sitting in a dark room with absolutely no mirrors, their mind is constantly reviewing their appearance, mentally measuring themselves against others.
That sounds agonizing.
It is. It consumes an incredible amount of mental bandwidth, which leads to markedly impaired functioning at work, at school, and in relationships.
Well, wait, let me stop you there and push back a bit.
Sure.
If someone with BDD knows, on some logical level, that the flaw is tiny, if their family keeps telling them, I literally cannot see what you're talking about,
Right.
why can't their rational brain just step in? Why can't they just logically talk themselves out of the panic and, stop checking the mirror?
Yeah, that is the incredibly frustrating reality of obsessive compulsive spectrum disorders, which is exactly where BDD lives.
Okay.
The logical part of the brain, the prefrontal cortex, is essentially overridden by the primitive emotional centers.
So logic just goes out the window.
Pretty much. When the amygdala is screaming that there is a threat, it doesn't care about logic at all. The compulsion to check the mirror provides a tiny, fleeting hit of relief.
It's a temporary fix.
Exactly. They look in the mirror, they try to find an angle where the flaw doesn't look so bad, and for maybe 5 seconds, the anxiety drops.
But then the doubt creeps right back in.
Exactly. The relief evaporates, the obsession returns, and the brain says, check the mirror again. You need that relief again.
It's basically an addiction.
It is an addiction to a false sense of safety. And eventually, checking just isn't enough. The avoidance takes over.
Like hiding away.
Yes. Many patients avoid social situations entirely because of how they believe they look. They isolate themselves. The perceived flaw becomes this prison warden dictating where they can go and who they can see.
Okay, so if the functional impact is that severe, if someone is spending hours a day in front of a mirror, missing work, skipping school, completely isolating themselves,
Yeah.
how on earth does this go undiagnosed? Shouldn't a primary care doctor or a therapist spot this immediately?
You would think so, but that brings us to one of the most tragic ironies outlined in the clinical landscape.
Which is?
BDD is constantly missed, sometimes for years or even decades. But it's not because these patients aren't seeking help.
Okay, so what is it?
It's because they're seeking help in the entirely wrong medical offices.
Oh, they aren't going to psychologists. They're going to doctors who fits physical problems.
Yes, exactly. They are going to dermatology clinics, cosmetic surgery practices, and orthodontic settings.
Right.
BDD is markedly underrecognized in these specific environments. And if you trace the logic from the patient's distorted perspective, it actually makes perfect sense.
Because they think it's a physical defect.
Right. If your brain is telling you that your core problem is a terrible skin texture or severe facial asymmetry, you don't book a therapy session to talk about your feelings.
No, you book a surgeon to fix the symmetry.
Exactly.
Here's where it gets really interesting and honestly, incredibly dark.
Yeah, it does.
The research highlights a terrible cycle where patients seek out repeated cosmetic procedures, right? Hoping that each new intervention, each new surgery or filler or laser treatment will finally cure their distress.
And this is the crux of the medical blind spot. Because the relief never comes. It is a fundamentally impossible pursuit.
Because it's a software issue, not a hardware issue.
That is a perfect analogy.
Right, you're trying to fix a glitch in the visual processing code by using a physical scalpel on the hardware.
Exactly. The underlying perception is the issue, not the physical tissue being modified. Let's say a patient with BDD gets a rhinoplasty, right?
Oh, a nose job. Yeah.
The surgeon might execute a technically flawless procedure, but when the bandages come off, the patient's brain, that local processing glitch and that hyperactive threat response is still functioning exactly the same way it was before they went under anesthesia.
Wow. So the cognitive distortion remains completely untouched.
Complete.
So they look in the mirror, the brain still hyper-focuses on the nose,
Yeah.
the alarm bells still ring, and the distress just rushes right back in. What do they do then?
Well, they assume the surgeon did a bad job, which often leads to anger or even litigation against the provider.
Yikes.
Or the BDD simply shifts its focus.
Oh, like it moves to a new target.
Yes. The nose is fixed, so now the brain's magnifying glass moves to the jawline or maybe the eyelids.
So they just keep going back.
The data shows these patients often cycle through multiple providers and undergo numerous procedures, never finding satisfaction. It's just a tragic loop of physical interventions attempting to solve a purely perceptual disorder.
Which means, logically, if modifying the physical body part is a total failure, the treatment protocol has to pivot completely. You have to target the obsessive preoccupation itself.
You do. And thankfully, the clinical guidelines are actually very clear on what works.
What are they?
The evidence-based first-line treatments for BDD rely on two primary pillars: cognitive behavioral therapy, or CBT, and SSRIs.
Which are a class of medication commonly used to treat depression and anxiety.
Exactly.
Now, regarding those medications, there was a highly specific medical detail in our notes that caught my eye.
Oh, yeah.
Yeah, it says that the SSRIs prescribed for BDD are often given at higher than depression doses. They actually fall into the dosage range typically used for OCD obsessive compulsive disorder.
That's right.
Why such a high dose, though? Like, what is the medication actually doing mechanically?
Well, it goes back to breaking that obsessive loop we talked about earlier. SSRIs increase the availability of serotonin in the brain.
Okay.
At lower doses, this is great for lifting a depressed mood. But at higher doses, serotonin has been shown to improve cognitive flexibility and calm the hyperactive circuits between the frontal lobes and the basal ganglia.
Which are the pathways trapping them?
Exactly, the pathways that essentially trap a person in those repetitive, compulsive behaviors. By utilizing these higher doses, psychiatrists are chemically lowering the volume of the obsession.
Making it easier for the patient to engage in the hard work of therapy.
You got it.
Which brings us to the therapy side. You lower the volume with medication, and then you use cognitive behavioral therapy to essentially reprogram the software.
Precisely.
So how does CBT specifically work for someone whose brain is actively lying to them about how they look?
Well, it requires a very specialized form of CBT, heavily utilizing something called exposure and response prevention, or ERP.
Okay, ERP.
Yeah, the therapist works with the patient to target those safety-seeking behaviors, the hours of mirror checking, the elaborate grooming rituals.
Right. Can you give me like a concrete example of what that looks like in a session?
Certainly. So, an exposure exercise might involve the patient standing in front of a mirror without makeup for 2 minutes and consciously stopping themselves from analyzing the specific perceived flaw.
That sounds intense.
It is, and the response prevention part means they are not allowed to engage in their usual compulsion to neutralize the anxiety.
You can't fix it.
Right. They can't cover their face, they can't ask the therapist for reassurance, they just have to sit with the extreme discomfort.
That sounds agonizing. Why put them through that?
Because of neuroplasticity. The ultimate goal is habituation.
Meaning they get used to it.
Exactly. By sitting with the anxiety without performing the ritual, the brain eventually learns that the anxiety will peak and then naturally subside on its own.
Oh, wow.
It teaches the amygdala, hey, we didn't check the flaw and we didn't die. This isn't an actual threat.
So it rewires the alarm system.
Over time, yes, this starves the neural pathway of the compulsion. And alongside that, they work on cognitive restructuring,
What do you mean?
challenging the underlying beliefs about appearance and retraining the brain to take in the whole face, the whole person, rather than zooming in on a microscopic defect.
It is literal brain rewiring. But here is the massive bottleneck in the system.
Yeah.
Knowing this highly specialized treatment exists is one thing.
True.
Actually getting a patient in front of a clinician trained to do it, that's a massive hurdle.
It's huge.
And this is where our research provides a really grounding, practical look at how modern care is adapting. We have some operational data from Coping and Healing Counseling, or CHC, which is a therapy practice out of Georgia.
It's a really important case study because accessibility is arguably the greatest crisis in mental health care today.
Seriously.
The most effective CBT model in the world is utterly useless if the patient who needs it cannot reach the clinic.
Exactly. And if we think back to the behavioral toll of BDD we discussed, the profound avoidance, the fear of being seen, the intense social isolation, the traditional model of therapy is basically a non-starter.
It really is.
If you tell a patient who is paralyzed by the thought of being looked at that they need to commute across town, sit in a crowded waiting room, and make eye contact with the receptionist just to get help.
They're just not going to show up.
Right. They simply aren't going to show up.
The logistical barrier compounds the psychological barrier. And that is why the telehealth model changes the landscape entirely.
Which is exactly what CHC is doing. Their data notes that they serve all 159 counties in Georgia through a 100% telehealth IPA-compliant model.
It's incredible.
It really completely bypasses the agoraphobic side effects of the disorder. I mean, you can start this incredibly vulnerable exposure therapy in the one place you actually feel safe, your own bedroom.
Yeah, telehealth removes the friction of physical presence. And it's vital to note that this isn't just like a generic counseling hotline.
No, not at all.
The operational details highlight a culturally competent team of over 15 licensed therapists.
That includes clinical social workers, professional counselors, and marriage and family therapists, right?
Exactly. They are bringing a full clinical arsenal directly to the patient's laptop.
They also treat teens from age 13 and up alongside adults. Why is that age bracket so critical when we're talking about body dysmorphia?
Because adolescence is typically when the neurological and social perfect storm occurs.
Oh, that makes sense.
Yeah, the brain's perceptual hardware is still maturing, peer comparison is at an all-time high, and puberty is rapidly altering the physical body.
It's a lot all at once.
It is. BDD very often takes root in those teenage years. So early intervention by licensed professionals can literally prevent decades of that tragic, fruitless cosmetic cycle we explored earlier.
But even with telehealth solving the geography problem, there is always the elephant in the room with American healthcare. The cost.
Oh, definitely.
The financial friction is often the final nail in the coffin for getting care. But the data from CHC specifically outlines a financial model designed to tear that barrier down too.
It's so necessary.
It is. For Medicaid patients, the copay is $0.
Wow.
And for major commercial insurances, they list Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, Humana. The copays range from just $10 to $40 a session.
Which is huge. By addressing both the geographic isolation through telehealth and the financial bottleneck through broad insurance acceptance, you create a viable runway for treatment.
It really democratizes it.
It transforms BDD-informed care from a luxury available only in major coastal cities into a genuinely accessible lifeline for that 2.4% of the population struggling in silence.
So what does this all mean? When we connect all these dots, the invulnerable neurological distress, the tragic misdiagnosis in cosmetic settings, the intense rewiring required by CBT, and the modern telehealth frameworks making that therapy accessible.
Yeah.
What is the ultimate takeaway for someone trying to understand this disorder? The clinical consensus points to one glaring mandate. Diagnosis must be made by a licensed mental health clinician.
Absolutely.
Patients desperately need care that treats the true root cause, the obsessive preoccupation happening inside the brain, rather than spending years trying to surgically alter the reflection in the mirror.
If we synthesize everything we've explored today, it really comes down to a fundamental shift in how we view the condition.
How so?
Body dysmorphic disorder is not a defect of the physical body. It is a profound, exhausting glitch in human perception. It's the brain's internal alarm system turning on itself.
Well said.
And the solution requires patience, evidence-based psychological intervention to literally rewire those circuits, and a healthcare model that meets the patient exactly where they are.
We want to thank you for joining us on this deep dive. We hope this exploration has provided a new lens through which to view body image and a reminder to be incredibly mindful of the unseen battles happening around us.
You never really know what someone's going through.
You don't.
Yeah.
The person standing next to you might be fighting a war with their own reflection that you cannot even perceive.
And as you move through the rest of your day, we want to leave you with a final thought to mull over.
Yeah.
If the human brain is powerful enough to completely distort our perception of our own physical, tangible bodies,
Right.
what other invisible, unobservable aspects of ourselves, like our intelligence, our personality, or the actual impact we have on the people around us, might we be viewing through an equally distorted lens without even realizing it?